Oh, I think everything is as it should be. My name is Mark Jordan. I'm a community pharmacist and a Pharma Buddy team member, and I have a special interest in cannabis, the compounds it produces, and their therapeutic potential and their ongoing therapeutic uses. So, you're all very welcome to the long promised CBD tutorial. Um, I suppose it does come with a small disclaimer at the outset. It's probably the most formal part of the entirety of the tutorial, and that is this tutorial is really only designed for informational purposes only. It is not designed to supersede any more relevant, clinical, or correct information surrounding cannabis, CBD, or THC. It is designed really only such that my colleagues, friends, and peers can get the benefit of the information that I've accumulated over the last kind of 2 years. I've gone away and verified and validated, as well as referenced at the end of this tutorial, so that they can build a solid foundation and go forward with their learning, such that they can decipher whether or not the information that they've been presented with is correct, relevant, and appropriate for what it is designed to be. So, that being said, I'm going to try and make sure that this tutorial is the most informal and enjoyable experience possible. Much like my colleague Dr. Paul Ryan, I want everybody to learn in an environment that they can enjoy, as I mentioned. And it's hard enough learning new information without it being overly bearing. So just there is some wordy slides in here, but we will have a quick skim over them. It does go without saying as well that if anybody has anything to add to this, please feel free to do so. You can do that in the comment section below where this link is posted, or indeed via your own post, as I normally say in other audio recorded podcasts. I think one of the things that struck me when I sat down to write this presentation, or to build the grounding that we're going to discuss from here on out, probably very naively so, was the fact that the amount of information available on cannabis, CBD, and THC is vast. It's absolutely huge. And it's probably one of the reasons that like pharmacists and other health professionals and scientists are so interested in it, can get sucked into the rabbit hole that is cannabis. Like, the fact of the matter is that no matter what you put into a search engine, within a matter of milliseconds, it regurgitates all sorts of hits back at you. But when you put in cannabis and therapeutics, or CBD and treatment, or whatever coupling of words that you want to put in to a search engine in relation to cannabis specifically, the absolute density of the information along with the volume is astounding. Right the way from highly funded and expertly conducted clinical trials and studies and papers, like the Barnes report, for example, that was used to validate cannabis as a medicinal therapy in the UK, all the way to anecdotal information of patients in the States using cannabis as a form of analgesia or as an antiemetic in chemotherapy. The volume of information is astounding, as I mentioned. But I suppose that's probably why I'm so interested in it as a topic. So I think maybe if we reverse a second and we just talk about how I actually got involved in studying cannabis. I think historically I always considered myself, and probably obnoxiously so, a man of science. And I remember leaving UCC the day I managed to get a hold of my bachelor's, and it was a very, very bright day, and it wasn't very sunny, but it was one of those big bright days. And I remember leaving one of the buildings on campus thinking to myself that I'm a modern day link in this historic chain of pharmacy and the rich tapestry that comes with all of the pharmaceutical sciences. And as a kind of a kicker off that, I think I was at the time a great believer in the old vantage that medicine that worked became medicine, and indeed medicine that didn't remained hocus pocus or snake oil and stayed in the travelling circus. But I think even at that stage, the tide was turning for me. I become interested in various sports towards the end of my term in UCC, and because of those sports, I developed on my understanding of nutrition, and I became enamored with all of this information that I had acquired from university, that I had accumulated over time, and I realized I could put it to good use in terms of understanding metabolic pathways and nutrition. And then as a kind of aside to that, I became very interested in I suppose, just exogenous compounds and how they elicit their effect, and that it wasn't just regurgitating information in exam settings, that I could put this information to good use. And I think soon after having qualified, I saw a series of documentaries on a particular channel, and it was about a guy who travelled the world investigating various therapeutic agents from corners of the Amazon to, the sub-Saharan plains, and he was talking in depth about the pharmacology of them and the organic chemistry that went into them, and it piqued my interest. And I think I soon realised that all of these learned skills I could put to good use. I was very, very conscious of exercising the scientific languages that took me ages to learn, like organic chemistry and stuff. And the godfather of all of these, I soon realised, was cannabis. So it became something I researched as a hobby, all the way from, as I mentioned, the organic chemistry I thought I'd never use, to the history of the American presidents, which I'd long since forgotten from second level, and their effect on the history of cannabis use, the prohibition in the States, which seems to be changing now, and I managed to just put it all to good use, and I found great interest and pleasure in spending my spare time learning this information. So in today's tutorial, we're going to take a look at all of these various facets of cannabis. Now, we're going to leave out the politics and the war on drugs, but we're going to concentrate primarily on CBD, as I promised. But I hope it's a great hope of mine that everybody who expressed such great interest gets the benefit that they deserve out of this. And as I mentioned, it's designed to be a good solid grounding of information so that everyone can go forward and learn further for themselves, because this is an ever evolving area of science and therapeutics. And I think in order to validate us as the experts on drugs and other health professionals as the experts in their fields, we absolutely have to know more than anyone else on it. And I think, open disclosure at the start, I think the therapeutic potential of the compounds that the cannabis plant produces is extremely high. I think the work that is being done in the various areas of the cannabis industry is all good work, but it does suffer from kind of an informational overload, and I think it probably contributed, as I mentioned, to the density of the volume of information when I went back to reference all of the information that I'd accumulated over time. And it's something that goes without saying. Like, there's three very broad camps belonging to cannabis as a whole, and cannabis therapeutics, and I find that very interesting. I think a lot of health professionals probably find it very interesting. Like, on one side of the table you have these academics who diligently get up and go to work every morning in order to validate the studies that they're involved in, and oftentimes they involve compounds that the cannabis plant produce, or synthetic variations of those compounds. They are working tirelessly to validate something that they believe in, as are the people on the other side of the table, the complete opposite, or the other extreme, which is the anecdotal claims camp. You could find anything in this camp from, CBD or THC cured my pencil chewing addiction, right the way to CBD cream cured my alopecia, and then but the problem is that everybody is trying their best. I do respect everybody has the best of intentions. Us as the healthcare professionals must absolutely side with the scientific theory and validation that is coming from the camp that we aspire to be part of. And I think maybe the camp that I'm part of is the foreground, the murky grey camp, and that camp at its very worst is subject to people who will use broadly understood scientific claims to validate anecdotal information that is from the other extreme camp. And it lends itself to an area of science that is very, very difficult to learn about. And as I mentioned, the aim of this tutorial is to give everybody a level playing field so that we can all learn together. So that being said, I think as I mentioned, we'll start at the start, and I think if we have just a quick look at the actual genus and the cannabis genus itself. So there are three plants or three plant types belonging to the species of cannabis. That's sativa, indica, and ruderalis. So if you look on the far left-hand side of your screen, you'll notice that there's a very, very tall, lightly foliated plant. That's a cannabis sativa plant. In the middle, then we have a densely foliated plant. That's an indica plant. And at the end, then we have ruderalis, which is a very small, sparsely foliated plant. So, it does go without saying now that there is varying opinions when it comes to the subspecies of cannabis. Ruderalis doesn't tend to be included as the third of the three. It tends to be included in the indica family. Now that's widely disputed, but it's relevant in terms of the context of this tutorial. I think it was just worth mentioning because it is an interesting note that ruderalis, really its only function is to facilitate crossbreeding or interbreeding between the sativa and indica plant, and that will become important as we go through the tutorial. It largely lends itself to varying concentrations of THC and CBD being produced by hybridized plants. So I think that's why I wanted to include this slide. If we just, from a means of differentiation between the three species of plant, you have the sativa plant, as I mentioned, very finger-like projections in its leaves, very thin serrated edges. Then the indica plant, it's easy to see why it's a very densely foliated plant. That's a very broad plant, or broad leaf with flat palmar leaves. They're also serrated, but not so much as the sativa plant. Next we have the cannabis sativa L. Now that is a variant of the sativa and indica plant, and you can see that it does share similarities when you're looking at the leaf itself. It's described as a low intoxicant, high fiber seed producing plant, whereas the other two are described as high intoxicant, and they're not great at producing fiber. Now you can, but sativa L, otherwise known as hemp, is very densely very dense construction from fiber comparatively to indica and sativa. We use it for those reasons. We produce proteins and milks from it, as well as obviously CBD. So next I just want to speak a little bit about the organic chemistry. I know that there's probably some of you out there, no more than myself, who still wake up and think to themselves, I wonder, did I do enough study for my organic chemistry exam that's up on its way, when in all actuality we started about 5 or 6 years ago and it was just a terrible nightmare. But it is worth including, and I'll get to why it's worth including, maybe largely to the dismay of some of the organic chemists out there who may be listening and or watching. Excuse me for my terminology in this next slide. I'm aware that it does suffer from a little bit of it's lacking in areas, we'll say. So if we just have a look at the top, we do have two primary compounds on the top left hand side of your screen, one of which is olive toluolic acid, and that undergoes dephosphorylation, with geranyl pyrophosphate via the prenyl transferase enzyme, and that produces the mother compound CBGA. Now the mother compound is considered the mammy cannabinoid. All other cannabinoids, of which there are 85, are produced in some way, shape or form from CBGA. So if we pay particular attention to the top two pathways, which is the THC pathway and the CBD pathway, we'll notice that THCA and CBDA synthase enzymes are involved in changing CBGA to THC and CBD respectively. They undergo decarboxylation via exposure to heat. They lose carbon dioxide to produce THC and or CBD, depending on whichever pathway it undergoes. So that's just a broad explanation of what's going on the screens in front of you. What I want to pay particular attention to is the similarities in the structures between THC and CBD. I find this extremely interesting. You'll notice that THC is a tricyclic compound with a long carbon chain on the end, and you'll notice that CBD is has two cyclical structures in its overall structure with the same carbon chain on the end. You will notice though that it's missing the central ring structure, and that's because that ring structure is open. Now, overall, the structures look nearly identical, and I find this to be absolutely fascinating that we can administer either or of these drugs to a mammalian cell and they elicit different responses, even though they are very, very similar. Now, there's going to be organic chemists and biochemists and pharmacologists out there listening and or watching this, telling their computer screens or their phones that that's obvious, Mark, because there's a carbon-to-carbon bond in the CBD, which allows the cyclical ring on the top left-hand side of the structure to rotate, and with it change its overall shape and maybe fit into different receptors that THC doesn't fit into. And they'd be correct in saying that. CBD is an allosteric modulator of the CB1 receptor, and we will discuss that as the tutorial goes on. But I just still find it very, very interesting that we have structures that are so similar, yet they elicit such widely different responses, and in many cases antagonistic responses. So for example, THC elevates blood pressure, but CBD has been noted to reduce blood pressure. So that's just one worth watching. I think it's very, very interesting. Just on a side note, they did actually try to force CBD to create that central ring structure, or to undergo cyclization, I think is the correct term, and lose the hydrogen atom that is attached to the oxygen atom, such that the oxygen can bind to the carbon, but it wouldn't. It's actually very, very difficult to do that. So for a while there, I think there was some people thought it'd be similar to pseudoephedrine. There'd be people coming in buying bottles and bottles of CBD to turn it into THC, but that indeed isn't the case. It's actually quite difficult to turn CBD into THC. It's not a very efficient chemical pathway. Now, I just want to have a quick mention about the methods of ingestion. So methods of ingestion I really just want to cover quickly, because next I'm going to speak about bioavailability. So we just have a quick rundown through the methods of administration, and the first of which is oral ingestion or capsules and edible food. So oral ingestion is probably one of the ways that most pharmacists listening to this would be most familiar with. We tend to either have capsules and or sprays at our disposal in the community pharmacy, so it's something that many of us would have come across. Edible foods, there are foods, there's various cookies and brownies, as I'm sure everybody is aware of, that do contain cannabinoids, some of which are CBD. I'm not sure about their bioavailability. I'm sure that the action of baking, cooling and heating probably disrupts the chemical structure in some way, shape or fashion, and therefore inhibits its bioavailability as well. Are we really going to get that much CBD into foodstuffs? Who knows? Sublingually, using concentrated oils, tinctures and sprays. I think this is, as I mentioned, the method that we're all most familiar with. It's also the method that is most safe. Inhalation of vaporized concentrates. There's probably many shops in your local area, as there is in the county town that I live in, that specialise in selling CBD products, many of which are vaporized concentrates. I'm not going to stand over them. I don't think anybody else would. There is propylene glycol in many of these vape concentrates. It's used as a carrier or a vehicle, and I can't imagine that it's the healthiest thing to be inhaling. Application of topical preparations such as ointments, balms and patches. I think going forward there is great scope for the therapeutic potential associated with the use of patches, balms and various other concentrates. Particularly I know down in UCC there's been great inroads been made into the administration of drugs through the application of topical patches. Once CBD does become subject to GMP and we move away from HACCP and the supplement classification it is currently subject to, I think we will see greater progress in terms of patches and balms and ointments. But for the moment, I don't think that patches are much of a viable solution to anything. The balms and ointments are nice, but really I again don't think that there's great bioavailability from them. And lastly, then we have PR or parectal suppositories. No, I haven't come across these personally. I do know they exist, and the only reason I included them is because they are very safe. And as you can see here in the bioavailability slide, they do have a relative bioavailability of approximately 30%, which is quite good. It's thereabouts with a sublingual ingestion. If you swish a sprayed or dropper of oil in and around the mouth for about 2.5 minutes, you get between 12 and 35% bioavailability. Now that is depending on the quality of the vehicle. It does tend to be MCT or coconut oil in a lot of the preparations. Now, my personal opinion on this is that it'd be better if we were using oils that were expressed by the actual plant itself. It lends itself to maybe a level of the oil is probably going to be more reputable if we're using oils that are expressed directly from the cannabis plant. I am, as I'm sure there is many of you, skeptical as to whether some of these brands do actually have CBD in them. Inhalation, approximately 40% when vaporized, very, very good bioavailability from inhalation, and it does, as everybody knows, gets directly into the bloodstream. But this method of administration is heavily influenced by the vehicle. As I mentioned, a lot of them use propylene glycol. I wouldn't be mad about using concentrated carriers like propylene glycol and then heating them up. I don't think it's probably the healthiest thing, and in the future I'm sure that we will be getting studies back telling us that that is indeed the case. As I mentioned, transdermal application largely ineffective, estimated in some cases to be approximately 5%. I think with the advances that we're making in topical applications, particularly in terms of patches and reservoir patches and stuff like that, we will be able to administer CBD in the future using patches. I think there's probably scope there as an analgesic or as an antiemetic or whatever, and to be administered via a patch. But at the moment, the patches that are available on the market don't seem to have great bioavailability attached to them. Now, next, we're getting into the heavy stuff. This is the pharmacology of CBD, and in particular, we're going to concentrate in this slide on the pharmacokinetics. So, for the purposes of the examples that we're going to be speaking about here, the literature that I referenced spoke in depth about a 600 milligram dose, which was administered in a capsulated oil-based delivery mechanism. The patient is a healthy male volunteer, and I think he was about 35 at the time of this study being carried out. He was administered CBD. It was noted that because of its poor aqueous solubility, oral administration was described as erratic at best, which influences obviously the pharmacokinetic profile of the drug. But as I mentioned in the previous slide, the bioavailability of CBD when it's administered orally is about 6%. So I understand that it would be better if we could have used the sublingual method of administration in this study, but this is the most valid study I could come across, so we'll just concentrate on this for the moment. In the healthy male volunteer, at intervals of 1, 2 and 3 hours after oral administration via an oil-based capsulated delivery mechanism, concentrations of 0.64, 2.98 and 6.42 nanograms per milliliter were observed. The drug is readily or rapidly distributed into the tissues of the human body, expressing a high volume of distribution, and that's approximately 32 litres per kilogram. Similarly to THC, CBD, because of its high lipophilicity, accumulates in the adipose tissue, which could explain why there's kind of a lag time in noticing the required effects of the drug. But then again, we are using very, very low concentrations in community pharmacy at the moment, and I think it's something, as we move forward, we will see concentrations similarly to the 600 milligram dose that was used in this study when the drug is reclassified as GMP, which inevitably it will be, in my opinion, at some stage. Cannabidiol is extensively metabolized in the liver. This is the interesting part again for me, primarily via hydroxylation, and it forms intermediate metabolites, the most prominent of which is 6-alpha OH, 6-beta OH, 7-OH and 4-OH CBD. That OH that they're speaking of is the OH at the base of ring B in the bicyclical structure that is CBD. That is the ring that has the long carbon chain attached to it. There is an OH group at the base of that ring, and some of the most prominent metabolites are 6-alpha-OH, 6-beta-OH, 7-OH and 4-OH, as I mentioned, and that's the OH they're referencing. So just to move on slightly, just to speak a little bit about the in vitro studies that were ongoing and how they lent themselves to how we discovered how this hydroxylation occurred. It was primarily via CYP enzymes, the dreaded CYP and its isoenzymes, and they were found to be capable of metabolizing cannabidiol. The enzymes or the isoenzymes that were most involved in its metabolization or metabolism of CBD is CYP3A4 and CYP2C19. Now, 2D6, 2C9, 1A2 and 1A2 or 1A1 are also involved in metabolizing CBD from its pure form. However, as I mentioned, 3A4 and 2C19 are the most prominent isoenzymes involved. Therefore, it is worth mentioning that if you are aware of medication that you're dispensing to a patient who is also asking for CBD, which is metabolized via a cytochrome P450 enzyme, please just go and check, because the advice that I'm giving based on the research that I've given is that it's advisable to avoid co-administration of CBD with CYP isoenzyme inducers. Now, the likelihood of inhibiting CYP isoenzymes at the dosages observed in the community setting is low, because we never administer really more than 40 milligrams across the day. But as I mentioned in one of the posts in the last couple of weeks, it becomes a problem when we have people who are also using CBD water and they're eating CBD cake and they're CBD infused foods, and we start to have clinically relevant doses at that stage, and it's very easy to find somebody who is actually administering in excess of 300 milligrams per day. Now, obviously, if they're administering it and they're eating it in foodstuffs, bioavailability is going to be low, so the risk it still remains low. But it's just worth noticing that GW Pharmaceuticals, who are the owners of Sativex, and I think the UK government have just commissioned them for supply of their CBD or their cannabis therapeutics, for lack of a better description, found that 40 milligrams of CBD did not interact with CYP enzymes and its isoenzymes when administered orally. But a later trial found that 25 milligrams of CBD inhibited the proper metabolism of frisium, allowing its metabolite norclobazam to accumulate in the blood serum. Now, this study was conducted in Massachusetts General Hospital. The only problem with it is that it involved children with refractory epilepsy, and the study group was very, very small. Now, it did conclude that CBD was excellent, very, very safe, and it was very effective in the treatment. If anybody wanted to go and check that out, I do have the link at the bottom of the tutorial, and you can click into it. I think they found that it reduced the frequency in about half of the children that were studied. It reduced the frequency of their epilepsy fairly significantly, but it did require dose adjustment of clobazam when administered concomitantly. Now, that means that in other words, we, instead of giving 5 or 10 milligrams of frisium at whatever end of the day, or at whatever intervals, we would need to dose adjust according to the blood serum concentrations of CBD if it's been co-administered. So it's just worth noting. I think it's probably to err on the side of caution. It's another reason I'm an advocate of reclassification of CBD to a licensed product, so that we can get prescribers involved in dose adjusting various different medications, and who knows, it could be a good thing. So the pharmacodynamics, it's the second part of the pharmacology that we're going to speak about in this lecture or this tutorial. Before entering into the pharmacodynamics of CBD, I just want to have a quick look at what and how the compounds interact within the human body. So if we have a quick look at this slide, it just mentions the endocannabinoid system. So the endocannabinoid system basically comprises of two main receptors, the CB1 receptor and the CB2 receptor. So the CB1 and CB2 receptors are G protein coupled receptors. They're a rich repertoire of intracellular functions. Clinically and fundamentally, we're not really interested in the CB1 receptor. More so, the CB2 receptor as it's expressed more widely around the body. It's seen that the CB2 receptor is found anywhere from the muscle to bones, to the immune system. It has an inherent activity in the immune system and is expressed in immunocells. The CB1 receptor is the one that interests me the most. It's the one that's found in the brain. It's the one that THC regularly binds to. And generally speaking, its primary function is to react to some of the endogenous compounds or the endocannabinoids that we express naturally in the human body. So the endocannabinoid system is, as I mentioned, a biological system. It utilizes endogenous lipid-based retrograde neurotransmitters to bind cannabinoid receptor proteins, which are expressed throughout the vertebrate central nervous system and peripheral nervous system. So the CB1 receptor is the one that is located primarily in the central nervous system, but not exclusive to the central nervous system. It is found in the peripheral nervous system, and mainly what's found in the peripheral system, but again not exclusive to the peripheral system, is the CB1 or CB2 receptor, excuse me. Now, in the late 80s, a newly developed in vitro assay allowed researchers belonging to a group led by Alwyn Howlett at St. Louis University to determine the existence of the endocannabinoid system, as they also demonstrated the presence of cannabinoid receptors at the same time. Now, this was reviewed by Howlett in 2005, and that paper is actually a little bit easier to follow if somebody wanted to go down and have extra reading. I'm not going to cover it now in too great a depth, but it's just to give you a little bit of background. Between 1990 and 93, then, the US National Institute of Health, along with Gerard in Brussels and Munro's lab in Cambridge, both classified the CB1 and CB2 receptors, or isolated the receptors, and they were characterized allowing for the confirmation of previous discoveries. So they basically, in conjunction with one another, backed up what Howlett had determined to indeed exist. So the CB1 receptors are found predominantly, but not exclusively, in the central and peripheral nerve terminals, where they mediate inhibition of transmitter release. According to Howlett et al., the distribution of the CB1 receptor accounts for several of the characteristics displayed by the receptor agonists, such as hypokinesia, catalepsy, and signs of analgesia in animals and man. That's a fairly important little two-line paragraph there. I'm basically just speaking about how Howlett and his team found that the distribution of CB1 receptors accounts for several of the characteristics associated with the use of cannabinoids, which is hypokinesia, catalepsy, and signs of analgesia in humans and animals. And I think that that's really important. So just hold on to that as we go down through the endocannabinoid system further. So the CB2 receptors, the G-coupled protein receptor, are most concentrated in the immune cells, and in terms of CBD, that's what we're most concentrated or most interested in terms of this tutorial, and it's likely to be involved in the modulation of cytokine release and immune cell migration. So for people like my own mother, for example, who suffer from rheumatoid arthritis, and they do express that CBD seems to be able to make their day slightly more manageable. CB2 receptors are also found in the central nervous system on microglial cells. So in 1992, Devan et al. Described a lipophilic ligand that readily displaced a potent cannabinoid, HU243. Now, the question remained after they described this lipophilic ligand: was the ligand an endogenous cannabinoid? One of the things that I found most interesting, and I should have really included it in the slide here, was that Devan et al. Actually worked with Pfizer to develop these synthetic cannabinoids, of which HU243 and another one, CP550, which was a triturated compound. They worked together to develop these synthetic compounds, from which we have many issues. They're highly hallucinogenic, highly psychoactive, and things like spice and these other psychoactive compounds, synthetic compounds that are being abused, particularly in the UK at the moment, are cousins, and indeed some of these synthetic compounds that were produced way back in 1992. The question remained when they realised that this compound had been displaced from the cannabinoid receptor by something else. Was it an endogenous cannabinoid? And this led to the discovery um, of the endogenous cannabinoids that the human body readily produces. So to establish this, a sample of the compound, which was in the region of picograms, I think, was sent from Devan's shared lab in Jerusalem to Aberdeen, and here it was confirmed that the compound was shared the ability of other CB1 receptor agonists to inhibit the electrically evoked contractions of mouse vas deferens. Now, another piece of anecdotal or interesting information that comes with that is that not only did they use novel labeling techniques when they triturated some of these synthetic cannabinoids, they then managed to notice that an endogenous cannabinoid managed to displace their synthetic cannabinoid. They isolated it. There was only picograms of it. There was only picograms of it. And they managed to ship it all the way from Jerusalem to Aberdeen. Then, by a sheer coincidence, they used mouse vas deferens. If they'd used the regular guinea pig samples that they use when they're evoking electric contractions in these deferens, it wouldn't have worked. It was by pure chance that they used mouse that day, and from this then the compound was synthesized. It was subsequently identified as arachidonyl ethanolamide, and it was later named anandamide, which is a Sanskrit word for the word bliss. And I think it's that story is a really it's a story that was essentially 20 years in the making. It culminated in 92-93 with the discovery of the first endogenous cannabinoid, which is anandamide, as I mentioned, or made a poor job of mentioning. And then they gave it this lovely name, which is a Sanskrit translation for the word bliss, and it's just one of those nice stories that comes from science. The discovery of anandamide was followed then by reports of mammalian cell tissues containing many other fatty acid derivatives acting as cannabinoid receptor agonists, and the most studied of which after anandamide was 2-AG or 2-arachidonyl glycerol. So the two endogenous cannabinoids that we're so concerned with, aside from THC and CBD, which are exogenous cannabinoids, are anandamide, as I mentioned, and 2-AG. And I think any of my gym junkie pals out there, or any of the fitness fanatics, of which there's loads these days, will be very familiar with these compounds, even if they didn't know their name, because they are associated with the endorphin side effect, or the feeling of wellness and good spirits that you get after exercising. So it's very interesting, and it's something that made me stick around a little bit longer to learn more about these compounds. So we can just have a look at them there. That's anandamide at the very top of your screen, and you can appreciate its similarity in the structure to 2-AG or 2-arachidonyl glycerol. You can also notice in a kind of if you squint and sit back from your screen, you can probably appreciate how THC and CBD can manipulate themselves to bind to the CB receptors, of which we have examples here on the right hand side of your screen. You'll notice that the CB1 receptor is a far more complex G-coupled protein receptor than the CB2 receptor. Having said that, though, they're both very, very complex receptors, and it's very interesting that they're G-coupled as well, but I suppose we can keep that for a different day. I don't want to be harping on about organic chemistry and biochemistry too much today, but nevertheless, these are the compounds that we express readily in our own bodies, and these are the receptors that they interact with. Now we can move on to the pharmacodynamics. So CBD does not appear to bind directly to CB1, as I mentioned way back at the start of this tutorial. In studies examining potential agonist effects, no measurable responses were found, with only one study citing a weak agonistic effect and another citing and describing an antagonistic effect, each at high concentrations. Now, neuroimaging studies found that CBD has a net opposite effect to that of THC. It yielded no increase in heart rate or blood pressure, but rather a reduction in both. And this is, again, the really, really interesting relationship. Even though their structures are so similar, they bind in slightly different places. So remember, CBD is an allosteric modulator of the CB1 receptor, and THC binds directly to the CB1 receptor. It must change the shape of this G-coupled protein receptor such that THC can no longer elicit its effects, which is really, really interesting. And the net results of these effects is a reduction in heart rate and reduction in blood pressure, whereas THC elevates both. The mechanism of action here is still unclear. However, it is generally accepted that CBD elicits its effects by a negative allosteric modulation of the CB1 receptor, therefore acting as a non-competitive antagonist for the actions of THC. So, this is just worth mentioning. When you have a hybridized plant, it's being produced for psychoactive properties. You have all of these little trichrome hairs that are expressed on the leaves, and as they begin to mature, the trichrome hairs start to produce an exudate. This exudate crystallizes, and in this exudate you have CBD, you have concentrated form of CBD and THC. The genetic profile or the genetic characteristics associated with that plant basically decide whether or not decide the ratio of CBD to THC, and therefore this elicits a different response. Now, the interesting thing to me is that given the information that we've just covered here, in that CBD is a negative allosteric modulator of the CB1 receptor and therefore acts as a non-competitive antagonist of the actions of THC, this explains the variable highs or effects that are elicited by ingestion of these compounds from different strains. So I've watched interviews of people who are explaining highs as they're experiencing them from these compounds and from different strains, and the differences in these highs is astounding, and this must be why. CBD may also interact with the endocannabinoid system through indirect mechanisms, i.e. enhanced action of anandamide by way of blocking its reuptake and inhibition of its enzymatic degradation. So, much like serotonin reuptake inhibitors, CBD comes along, blocks the reuptake of anandamide, and inhibits its enzymatic degradation. Therefore, there is more anandamide, which would explain one of the reasons that CBD is being announced as a wonder drug or a wonder supplement in Ireland, as a means of combating anxiety and depression. So, if it would stand to reason that if you have more anandamide floating around in the intracellular fluid in your brain, then you would feel better. CBD has also been shown to interact with several non-endocannabinoid signaling pathways. These include enhanced 5-HT1A receptor activity, blockade of the GPR55 receptor, an orphan G-coupled protein receptor, and inhibition of adenosine reuptake, which possibly results in its agonistic activity at the adenosine receptor. Now, despite this, it is unclear if any of these actions are responsible for the apparent therapeutic value of CBD, or indeed any of the other effects it may elicit. But having said that, if we were to think critically about it, we could probably come to our own conclusions. But these studies need to be conducted. Particularly, they need to be conducted on a wider scale, and particularly we need longer and more densely populated studies to validate exactly what we're speaking about here. But it's very interesting nevertheless. Now, the toxicology of CBD, and this is one that some of you expressed a great interest on the forum when I said, what do you want me to cover? The toxicology of CBD is considered to have a relatively low level of toxicology associated with it. So to date, the following are the most relevant findings of in vitro and animal studies in relation to the toxicology observed. Limited research shows no effect on embryonic development. I'm not saying give it to pregnant ladies, but it's lipophilic, and it probably will readily dissolve across all barriers, but it doesn't seem to have any impact on the embryonic development. Now, having said that, THC has been shown to do that, so I wouldn't be taking the risk. And if somebody wanted to use a balm, I'd probably be okay with letting that happen, given that there's no real absorption. But again, It's not something that I'd be terribly comfortable with, nor should any of you, I think. There has been no effect observed in a wide range of physiological and biochemical parameters, including animal behaviour, unless administered in doses of which excess 30 milligrams per kilogram orally for prolonged periods, or 150 milligrams per kilogram as an IV acute dose. Potential for CBD to be associated with drug-drug interactions is real, but as I mentioned, research has yet to develop on whether or not this may occur at the physiological concentrations typically observed. We're not going to be administering really more than 40 milligrams in a day. It's got price limitations associated with it. It also has whether or not the brand is reputable, whether or not the carrier is any good. So there's all these other contributing factors. I don't think it's a real concern in community pharmacy, but having said that, it's something to be aware of. It is a developing area, and I think in the future we will be keeping an eye out for patients who are being co-administered drugs which are particularly metabolized by the liver, and in specific terms by the cytochrome P450 enzymes and its isoenzymes. CBD affects the growth of tumour cell lines. Interestingly, a pro-apoptotic effect has been observed in lymphocytes. So if we just look on the bottom right hand side of your screens here, you'll notice that a before and after slide is available for your viewing pleasure. The before slide obviously shows an apoptotic effect to be apparent on the right hand side rather. So we have cell proliferation on the left, and we have cell death on the right, and that is after administration of CBD. Now, to continue on with the toxicology, the adverse reactions, abuse potential and dependence potential. There's not a whole lot to say here. CBD is very, very safe, is the net finding. Adverse reactions, as discussed, CBD failed to produce any of the effects otherwise observed when cannabinoids such as THC is administered. CBD is generally well tolerated and enjoys a good safety profile. In studies involving mice where they were injected once daily for 14 days with either CBD or THC, tolerance was observed only with THC. In studies involving rats, low-dose CBD did not change the threshold frequency required for intracranial self-stimulation. In high-dose administration of CBD, elevation of the threshold was observed, suggesting that a reduction in reward activity was the case. So their method of understanding whether or not something has a potential for abuse or a potential for dependence is to investigate the threshold frequency required for intracranial self-stimulation. When they administer things like cocaine, opioids, methamphetamines, it lowers this threshold, where indeed when we administer CBD, it elevates the threshold, and this therefore shows that there is a reduction in reward activity when you administer CBD, unlike cocaine and opioids and methamphetamines, etc., which means that there is a very, very low abuse potential and or dependence potential associated with the use of CBD. CBD was shown to have no effect on the firing rate of dopaminergic cells in the mesolimbic ventral segmental area nucleus accumbens pathway. This is in contrast to drugs with a high potential for abuse. So if we look at its sister drug, THC, it works in the same area. It increases dopaminergic firing rates, and it's associated with the warm feeling that that cannabis users express and feel when they administer the drug. And this is in stark contrast to CBD. CBD does not increase the firing rate of dopaminergic cells. So overall, as far as abuse potential and adverse reactions and dependence, it's very, very low risk with this drug. Now, the therapeutic applications of CBD. Now, this is probably where we're going to see if we can conclude the tutorial in its entirety. And I think it's probably somewhere that I'm not going to be able to do justice. I'm not saying I did a great deal of justice to the actual topic as a whole, but it's evolving so quickly. The use of CBD and THC and cannabinoids as a whole, of which there are 85, and the two primary ones is the THC and CBD, as I mentioned. it's developing so quickly that it's very, very difficult for us to nail anything down. So what I did was I consulted the WHO about what they're saying are the therapeutic applications of CBD, and if they're saying it, I think we'll go with what they have mentioned, and who they reference is Pasanti et al. In 2017, so it's very recent. Um, and it'll give us all a very good grounding, as I mentioned at the outset of this tutorial, to move forward when the studies become broader and more in depth. So the clinical use of CBD is described by the WHO as most advanced in the treatment of epilepsy, which I'm sure all of you are aware. Epidiolex being the primary drug of interest in this instance. The history of CBD used in the treatment of epilepsy dates all the way back to the 1970s, where animal models have been shown to have a reduction in seizure activity upon exposure to the drug. So, many of the studies conducted to date are in relation to multi-drug resistant epilepsy, of which CBD holds much promise, with studies citing monthly frequency of motor seizure reducing from 30 at a baseline to approximately 15.8 over a 12-week period. So that's actually very good. It's just shy of exactly half in 3 months. For a little compound like CBD, given the amount of time and energy that goes into other compounds that have been brought to market, that's excellent. Other possible therapeutic benefits of the drug were described by Pasanti et al. In 2017 and are listed as follows. I'm not going to concentrate too much on them. Alzheimer's, CBD has an anti-inflammatory effect. It's an antioxidant. As we mentioned, it's anti-apoptotic in vitro and in vivo models, and therefore is shown to be neuroprotective and shows a reduction in the neurodegenerative processes. So that has to be developed on, but it's showing good promise. Parkinson's disease, I'm sure you've all seen the attenuation of the dopaminergic impairment, and that is expressed in those videos that we see, those viral videos of people. Now, that in fairness, it's mainly THC that's been administered there, but CBD, again, to reference its neuroprotective qualities, the improvement in psychiatric rating and agitation in patients. They also noticed a reduction in nightmares and aggressive behaviour experienced by these patients. So that's another good one to keep an eye on. So the next one is multiple sclerosis. So particularly in the Barnes report, there's a great deal of reading. I'd highly recommend everybody read the Barnes report. Hopefully we'll be able to sit down and have an interview with Professor Barnes. Multiple sclerosis immunomodulator improves signs of ENA in mice, and obviously, as I mentioned before, it's an anti-inflammatory. In Huntington's disease, there's no real significant clinical improvement in humans. However, as mentioned in the other couple of examples, CBD does have a neuroprotective quality and an antioxidant quality, and that's been observed in transgenic mice to have had a benefit. Next, we have pain. Great deal of research being done with CBD and pain. It does seem to reduce pain experienced by patients who are in chronic pain. Analgesic effects in patients with neuropathic pain have also been examined. That's another one where the Barnes report did a great deal of work in synopsizing some of the more relevant therapeutic studies that were ongoing. It has been administered with it's either pregabalin or gabapentin or both. I'd need to double check that, but it did show a reduction in pain. Psychosis, attenuation of behavioural and glial changes in animal models of schizophrenia, antipsychotic qualities were associated when it was induced by ketamine in these animal models. So it did show promise there. Also, it's worth mentioning that there is an antidepressive effect in genetic rodent models of depression, reduction in muscular tension, restlessness and fatigue. So it is something that could be recommended for acute anxiety and stress, given that you're able to equip the patient with the information that they require should they not feel any great deal of benefit from using CBD. So as I mentioned, Mepora umami, rheumatoid arthritis, it does CBD does inhibit TNF alpha in animal models. I'm not sure about the dosages. I think there's a great deal of work that needs to be done there. It's one to watch, and I definitely think out of all of these examples here, rheumatoid arthritis, pain, multiple sclerosis, and anxiety and depression are the ones to watch going into the future. I do have notes there about infection, shows activity against methicillin resistant staphylococcus, and also cardiovascular disease, reducing infarct size through anti-inflammatory and antioxidant properties in vitro studies. It's very, very interesting. There's a lot of work been done on it, and I think just to give you my clear intentions in completing this tutorial, I don't see this as the absolute full stop for CBD, and I also equally don't see THC and CBD and cannabis as the wonder drugs that they're expressed to be in many platforms. But my own bias on this is that they do have great potential as therapeutic agents. I find it extremely interesting that we have these exogenous compounds that can mimic and interact with mimic endogenous compounds like endocannabinoid and 2AG, and work with the endocannabinoid system to elicit these responses that can be beneficial to us in terms of epilepsy, Alzheimer's, anxiety, rheumatoid arthritis, inflammation, etc., etc. It's an area that I think is ever expansive. It's growing day on day. People have been working in this area since the early 70s. It's not new information. It's becoming widely accepted, and I think if we as a profession embrace the 85 characterized cannabinoids from the cannabis plant, and we're informed about them when these cannabinoids are reclassified as medicinal compounds, and we remove them from the supplement category that they're beholding to now, we will be the ones with the answers. And my deepest hope is that we're all ready and equipped to be the ones with the answers. I think many of you are already in that position where people are coming to you looking for answers. We're the ones that are the experts in the drugs, and I think it goes without saying that these have great potential to be therapeutic drugs of the future, and indeed in many cases are therapeutic drugs of now in terms of Sativex and the other drugs that are available on the market. Just before we wrap up, I want to just have a quick skim over what we learned. So we learned that there's 3 plants in the actual family, the cannabis family. That's sativa, indica, ruderalis. Our plant of choice at the moment in terms of this tutorial is Cannabis sativa L, aka hemp. We used hemp to produce seeds, fiber, and CBD. It's a low intoxicant form of the species. Sativa and indica are crossbred to produce high intoxicant forms of the species or subspecies. We then moved on to the pharmacology of the drug. It's metabolized by cytochrome P450. Watch out for anybody on something like losartan or frisium. Losartan, it'll increase the concentration of the active metabolites of losartan, as losartan is also metabolized by cytochrome P450. CBD has an antihypertensive effect, as is the case with losartan, obviously. Will the person collapse? Probably not, but are you going to be the one that is going to wait and see? Also, probably not. So keep an eye out for the people who are being co-administered drugs who are also metabolized by cytochrome P450 isoenzymes. Then we moved on to the toxicology. It's very, very, very safe. Very, very low chance of dependence or abuse. In fact, showed the absolute opposite of drugs that had a high potential for abuse. We spoke about the endocannabinoid system, its expression around the body. So the CB1 and CB2 receptors are G-coupled protein receptors. CB1 is primarily expressed in the central nervous system. CB2 is primarily expressed in the peripheral nervous system and on immunocells in particular. And then finally we wrapped up with the therapeutics and the applications of CBD both now and in the future. It's used as an antiemetic in cancer. It's been shown to be an anti-proliferative, anti-invasive medication with actions in a large range of cancer types. It shows an induction in autophagy, mediated cancer cell death, and chemopreventive effects. It's an antiemetic. It suppresses nausea and the condition of gaping in rats. We mentioned Alzheimer's, its anti-inflammatory effects, Parkinson's, its attenuation of dopaminergic impairment, pain. It's got an analgesic effect in neuropathic pain. Rheumatoid arthritis, it inhibits TNF alpha in animal models, therefore probably does the same in humans. It's great in animal models so far as an anti-anxiety agent or an antidepressive medication, a reduction in muscular tension, restlessness, fatigue, an improvement in social interactions in rodents of anxiety and stress, and an antidepressant effect in genetic rodent models. So I think, generally speaking, we're speaking of a plant that has a high potential. It produces these compounds readily. It's very, very efficient to grow. It grows very quickly. We can manipulate the atmosphere in which it grows. We can produce these compounds very readily. It's low cost, energy saving, and has potential to serve the human population going forward, should we as scientists, health professionals, and as a greater population be open to the possibility of that occurring. It may not occur. Equally, we might find that all of these actions of CBD and THC are balderdash. They mightn't work on a clinical level at all, but we want to know, and we're the experts that should know. Just following on from this, I did do a small experiment myself. It didn't really work out. This is contact dermatitis. It probably would have worked in the absence of a balm or a cream. As I mentioned, I probably do belong to the grey camp in the foreground, and I am a part-time anecdotal scientist. But I just thought it was an interesting one, and I have included it at the end. Anyway, these are my references. You're all very welcome to investigate them, have a look at them, have a dig around in them. These are some of the studies and papers that I referenced most commonly. And the only other one that I think that possibly isn't included there is the Barnes report, which is something I think everybody should investigate over the coming weeks. And indeed, if there is interest there, myself and Professor Michael Barnes can sit down and have an interview so that we can educate and develop on some of the information that we have covered throughout this tutorial. So, as I mentioned, I'm Mark Jordan, community pharmacist, Farm Buddy team member. This has been a brilliant experience. I'm delighted that everybody had expressed such great enthusiasm when I offered to do it, and hopefully I have the opportunity to develop on some of this and or do some other tutorials going into the future. So that's me, and thanks very much. We'll see you the next time.